The next talk will be given by Dr. Mahmoud Moshabasha. The title of the talk is a survey on utilization and approaches to intracranial extracranial vessel MRI.
Thank you so much, and thank you. I want to thank the organizing committee for inviting me to speak on this topic and to present to you. One second. I'm just figuring out what buttons to push here. This one? This one. Okay, perfect. So first we'll talk a little bit about introduction of vessel wall MRA, results of a survey we did, and potential steps to address the gaps. So I listened very intently to the discussion this morning and the excellent presentations from Jeff Rubin and from Martin Prince about MRA versus CTA. And I think I agree with both of them, and that's not just me with being a politician. But in reality, I think each of them excels in specific areas, and creating specific lanes for each and applications for each is really what's necessary. And I think the discussion about MRA not really advancing, I don't necessarily agree with that. What I think is, instead of advancing in a linear line, it's more advanced, and creeped in different directions. And one of those directions that it's really advanced in is vessel wall application. So vessel wall MRA or vessel wall imaging is certainly an MRA technique. While it may look like an MRI brain or an MRI application, really what we're evaluating are the vessels and the arterial and venous abnormalities, and in that setting it is angiographic. What I do want to mention is there is a bit of a gap there in terms of the way this is assessed. In the literature, a lot of papers are vessel wall MRI, intracranial or extracranial vessel wall MRI. And in that setting, with publications, with lectures, with educational activities focused on vessel wall MRI, it does contribute to the coding of these. And so not until recently, until 2020, was this addressed with the ACR, ASNR, SNIS, SPR practice parameters, where vessel wall imaging was lumped in with MRA. And in that setting, the recommendation is that it is an MRA exam, and it should be coded as such. But still, the issue is, in a lot of institutions, it's still coded as an MRI with and without contrast, as opposed to an MRA. And not at all institutions is a time of flight MRA performed with the vessel wall imaging. So I think this is a gap here that may potentially affect some of that CMS data that we are seeing, showing a decline in MRA performance. It may not be a huge contribution, but I do think this is something to keep in mind. And I do want to mention, when you look at the literature, as I mentioned, vessel wall MRI, looking up intracranial vessel wall MRI will result in almost 1,000 publications over a number of years, while intracranial vessel wall MRA produces only 100 publications. And a lot of those are actually papers where it's referred to as vessel wall MRI as well. So certainly reappropriating things like vessel wall imaging and 4D flow and other advanced techniques that have been directions that MRA has expanded into, reappropriating them to MRA certainly, I think, is of benefit. So back to what I intended on talking about. The impact of vessel wall imaging has certainly been, intracranial vessel wall imaging has certainly been seen on clinical practice. It provides improved diagnostic accuracy in intracranial vasculopathy differentiation. It provides value in intracranial stroke risk stratification and in assessment of aneurysm risk. So a couple papers I'll discuss here. One that we published not too long ago, where we looked at the improvement in diagnostic accuracy when vessel wall imaging was included for intracranial vasculopathies. And we found a significant improvement in diagnostic accuracy across the board when vessel wall imaging was included, from about 30% to close to 90% accuracy. And this was significant for every disease category: atherosclerosis, vasculitis, and RCVS. And we did a similar study with moya-moya vasculopathies, and again, we found significant improvements in diagnostic accuracy when vessel wall imaging was included, from about 30% to close to 90% with vessel wall imaging. In addition, a paper we published recently where we used a new post-processing algorithm to evaluate atherosclerotic plaque on luminal imaging as well as on vessel wall imaging, and we found no relationship between the degree of stenosis on luminal imaging and the maximal wall thickening of atherosclerotic lesions. So in that setting, atherosclerotic plaques can reach advanced stages without any abnormality on luminal imaging. And vessel wall imaging can certainly be helpful in terms of detecting non-stenotic atherosclerotic plaques that can result in stroke secondary to osteal occlusion or secondary to plaque rupture. And plaque enhancement and total plaque burden and plaque number can play a role in terms of recurrent stroke events. On ROC analysis from another study of ours, we found that the AUC was highest for these vessel wall imaging characteristics in terms of prediction of recurrent stroke. And we all know about the wonderful work that's been done in extracranial atherosclerotic disease over many years by many within this very room. But carotid atherosclerotic plaque using vessel wall imaging can certainly better predict association with stroke as well as risk of recurrent stroke, specifically in looking at embolic stroke of unidentified source. It can really help categorize that risk. So in terms of the survey, this was a survey that we did of ASNR membership, and we looked at utilization of vessel wall MRA, not MRI. See, even I'm brainwashed. We had a total of 532 respondents, of which we included 411 responses. And those that were excluded were because they spent less than 10 seconds on the survey, didn't respond to any questions, or there were redundant institutional responses, multiple responses from the same institution. 81% of respondents were from North America, but we also had respondents from Europe, Asia, South America, Australia, and a few from Africa. 76% of responses were from the US, 53% from academic practices, and 39% from private practice. In terms of the positive response rate between regions of the world, the US was at 47%, with the highest performance of intracranial vessel wall imaging in the eastern and western coasts of the US. I like to think the places I've been seem to perform vessel wall imaging a little more, but maybe that's giving myself a little too much credit. Less commonly performed in the southern and midwestern states, while the positive response rate within internationally was much higher, although I do think this relates to bias secondary to limited responses from these countries and probably respondents from higher end academic institutions that are likely performing more advanced imaging are more likely to be members of the ASNR. But this is data that we're going to look into more and hopefully get additional information on. In terms of utilization, far and away, the most common application for intracranial vessel wall imaging is vasculopathy differentiation. Is this atherosclerosis, vasculitis, RCVS, so on and so forth. Other common applications are culprit atherosclerotic plaque evaluation, cryptogenic stroke assessment, and aneurysm characterization. In terms of frequency of performance, about a quarter of respondents indicated that they performed it at least twice per week, with more than 70% indicating that they were performing it at least 1 to 2 times per month. So it is frequently utilized in those groups that are performing it. In addition, in terms of protocol approach, most were adding it on to stroke MRI or MRA. It was being added on by the radiologist, or it was a standalone exam ordering by the ordering providers, the neurologists or the neurosurgeons. Those are the three most common responses. And in terms of field strength for intracranial vessel wall MR, 3T was most common, followed by both 3T and 1.5T, with a small minority performing it only on 1.5T. In terms of sequences deployed, almost all institutions were using T1 pre and post contrast, vessel wall MR. 3/4 were performing time of flight MRA, while a smaller proportion were performing T2 weighted vessel wall and contrast enhanced MRA. And then in terms of the reasons why groups selected the protocols that they did, and it's not only those protocols, but also whether they performed 3D or 2D, was based on literature, based on lectures at societies such as this, and also based on guidelines from the societies, such as the ASNR Vessel Wall Imaging Study Group or other white papers from societies. Other reasons for application were time constraints. You have a busy clinical service. and you have limited access to that MR. So keeping those time constraints in mind in terms of that protocol development, as well as technical limitations based on scanner environment and protocol development. So in terms of those not performing vessel wall MR, there are a number of reasons for this. Limited interpretation or technical experience or clinical applications or understanding, or lack of radiologist or ordering provider interest in implementation. What I will mention is that of the respondents that did not perform vessel wall imaging, 55% indicated that if vessel wall imaging obstacles were overcome, that they would perform vessel wall imaging. So there is certainly a space in terms of gaining additional utilization within the radiology community. I do want to mention overall, more than 50% of respondents, I should have mentioned this before, but over 50% of respondents indicated that they were performing vessel wall imaging, and this does not only apply to academic institutions, as 62% of the academic institutions indicated they were performing it, and almost 50% of the private practices indicating that they were performing vessel wall imaging in their practice. In terms of order provider interest, stroke neurology was far and away the most common group that was indicating interest. But I do want to indicate that 32% indicated that no clinicians had expressed interest. And this is probably that gap we discussed in terms of understanding of the technique and its value and its applications. So transitioning to extracranial vessel wall imaging, performance by region, and I do want to mention this paper is currently accepted with revisions in AJNR. It's a nice short list of revisions, which I certainly am appreciative of. They're not making me, walk on my hands on a tightrope or anything like that, fortunately. In terms of the performance of extracranial vessel wall imaging, the performance is less frequent, where only 22% of groups in the US are performing it. Pretty even across the board between the eastern, southern, and western states, while uncommonly being performed in Midwestern states. And again, for the same reasons, we have higher favorable responses internationally. In terms of its performance also, there was maybe a little more variability in terms of the frequency of its performance, where 37% were indicated they were performing it at most once every couple months, while 32% on the other end were performing it at least one time per week. I think maybe that data, so in terms of the techniques used, T1 pre and post were most common, similar to intracranial, a little more 3D T1 gradient echo like SPGR, MP RAGE for intraplaque hemorrhage detection, and a lot of groups were performing multi-contrast protocols. Again, 3T scanning is most common, but a higher proportion were performing 3T and 1.5T. And in terms of protocol approach, it was very similar, where it was add-on either from the radiologists or clinicians or a standalone from clinicians. And then in terms of indications for performance, this was interesting because the most common application was the large artery vasculitis, followed by atherosclerosis evaluation and intraplaque hemorrhage detection, and then dissection characterization. I think this is important because large artery vasculitis is a very uncommon disease, as we know. And this speaks to maybe incomplete understanding of the value and applications of vessel wall MRA for atherosclerotic assessment and really the added benefit that you gain from it in terms of stroke risk stratification. And a number of the barriers were very similar in terms of technical expertise and understanding, clinical applications, as well as interest that also belie that lack of potential knowledge in terms of the techniques. And similarly, stroke neurology was the most common ordering these exams, but a large proportion of groups indicated that no clinicians were interested in extracranial vessel wall MRA. So in terms of the challenges we face, as we mentioned and we drilled on, the lack of knowledge of clinical applications and value from both the radiologists and the ordering providers is a major issue, and this leads to a lack of interest. If you don't understand something, you're probably not going to be interested in performing it. Lack of technical support for protocol development, as well as interpretation challenges from that lack of expertise, and no standardized protocols between institutions and vendors. So in terms of potential solutions for this, I think an increased focus on and emphasis on vessel wall imaging both in terms of national and international societies through publications, presentations, webinars, and other activities to really emphasize the value of these techniques. Increased engagement with vendors and technical leaders, whether institutional or national, for protocol development, and really standardizing these across vendors in terms of parameters, and having these distributed from vendors who are usually the first point of contact for many radiology groups and or societies. And in this setting, I think that standardization improves that translatability of the results of literature. It also improves collaboration, research productivity, and many other facets in terms of this performance. And developing automated processing tools for increased interpretation efficiency is very important so that interpretation becomes faster, it becomes easier, smaller learning curve for those that are not familiar with the technique going forward. So thank you so much. I appreciate your time.